wave, but where we are at this particular time.
Breakfast with Refilwe Moloto
on Cape Talk.
Professor, good morning. Always such a pleasure to have you on the show. How are you doing this morning?
Very well. Good morning, Refilwe. Good morning to all of the listeners. I'm actually in Cape Town.
Oh, my
Cape Town
goodness.
ICC.
Why aren't you in the studio? Okay, well, next time. I know you're very busy. And what brings you to Cape Town, out of interest?
There's a conference at the Cape Town Convention Center on research integrity, and I'm speaking this afternoon.
Of course you are. Research and integrity is your alley. Okay. Let's talk a little bit about where we are with respect to this peak that you had already perceived, and we'd discussed before it started, if you recall. And you were like, yeah, there's going to be a fifth wave. It's probably going to look like this. It's going to come, before winter, etc. What are your thoughts as to how it has played out?
So when we look at the epidemic in South Africa, we've seen that our waves are pretty irregular. We get about a 3-month gap. So we anticipated in February, when I was asked, I said, well, we can expect that the first wave will occur early in May, and it was declared on the 7th of May. So we know that we will see these waves. What is concerning to me is that we can't really predict how severe the next wave is going to be. Now, we have some idea that because we have high level of vaccine immunity, and we need to get better with that, and we have a high level of natural immunity. So between those forms of immunity, we have some protection. But the whole thing about viruses is that they're getting smarter and they are able to escape our immunity. And that's what's of concern, especially natural immunity. Vaccine immunity is a little bit harder to overcome, but natural immunity is easier to escape. So that's what our big concern is.
I see. And many people, anecdotally received their feedback to say, well, and that's the reason that I don't even want to bother getting a vaccine, because you've said that it's not as protective to have the natural immunity, but many people say, well, this thing is going to get smarter anyway and come around the corner in a different angle.
They're just wrong about that, because when you look at the breakthrough infection rates, if you look at individuals who had vaccinations and their chance of getting infected, for example, with the Delta variant, that the protection that the vaccine provided was still in the region of around 88%. So that means you were still getting protected. The problem is with Delta, there were so many infections that we saw quite a lot of breakthroughs. But there were a whole lot of people who were vaccinated who were protected. On the other hand, people who had natural immunity from the past waves, they had very little protection. So we know that when you've had natural infection, you just need one dose of the vaccine to give you something called hybrid immunity. That hybrid immunity is actually the best form of immunity. I'm sad to say this, but getting naturally infected, I wouldn't advise that. And getting a vaccine, that combination is what will give you the best protection against the current variants and possibly against the future variants.
Prof, you know what I've been hearing a lot of lately? I've been hearing a lot of people going, for 2 years I avoided this virus, and boom, I'm suddenly getting it. Many people are saying that they had managed to avoid getting the virus. Is there something about this particular Omicron variant, subvariant, that is a little bit more spicy?
Yeah, you're absolutely right. So there's very good biological reasons for what you are seeing. So we have seen this across the board. For example, China, that was able to keep the virus out, can't keep Omicron out. Omicron is just too highly infectious. Now, why is that the case? Omicron has so many mutations compared to the original virus. It's got over 50 mutations. So it is quite a different virus from the one we originally encountered from Wuhan. Now, what's given Omicron this difference in these mutations is that its ability to infect cells. Now, Omicron is about 70 times, 70 times more efficient in the way it infects the cells of the nose. But it is about tenfold less efficient in the way it infects the cells of the lungs, called the alveolar cells. So what we are seeing is that research, when you translate it into what you and I are seeing, we are seeing a highly infectious virus because it's growing so well in the nose and it's pouring out virus and infecting everybody. But when people get infected, the virus doesn't actually go down into the lungs and cause lung infection to the same extent. So we call that, it's much more milder because we're not seeing the respiratory distress. So the biology of the virus is translating into what you and I are seeing. And because of its infectiousness, excuse me, it's now causing very widespread infection.
So, Prof, okay, bear with me here. In my mind, I've never had the virus. Am I lying?
No, so in any viral disease, there will always be a small group of people who don't get a disease. Not always, but almost always. Now, those people, we need to study them because, I've never got natural infections as well. But,
obviously,
that's because I'm very careful.
Yes.
But those individuals often bear some kind of advantage, genetic advantage, or some kind of anomaly in the receptor that the virus uses. It's the same in HIV. In HIV, there's a small group of people who have an anomaly in the CCR5 gene, and so they don't get infected with HIV. So there will be a small group, but we haven't picked who that is yet, and it'll probably be quite a small group. Okay. But in most infections, there'll be some people we can expect that won't get infected. Whether you are one of them is a different story, because often this virus causes a very mild infection, so you wouldn't have even noticed.
But here's one of the things that I didn't mean to ask this question. I was happy to leave it, but I've heard that people with similar DNA respond to the virus the same way. And my sister was hospitalized, so and so was my father. So I'm of the mind that I would have noticed.
No, it's not necessarily true. No. What seems to be most important in predicting whether you get severe disease seems to be age. Age plays a huge role. So when you are above the age of 60, your risk of getting severe disease, although it's changing with the different variants, is around 8 to 10%. And when you get to above 70, it's over 14%. So whereas when you are 30 years old, it's very, very small. So it just depends on age, and it also depends on whether you have other illnesses like diabetes and hypertension. Those seem to be the most important. Genetics seems to play a very small role, if any.
It's sweet that you think I'm young. Professor Salim Abdool Karim. Always a pleasure catching up with you. Have a wonderful time at your conference, and thank you so much for this brilliant insight this morning.
Absolutely a pleasure for you.
Director of CAPRISA, Professor Salim Abdool Karim. It is 7:29. I have 30 seconds to let you know what I feel quite strongly about.
Breakfast with Refilwe Moloto.